Karen, Lindsay, Suzanne, and Tereska. We're here for a panel on internalized stigma, which is a major barrier for people with substance use disorder. Organizations across the SUD and recovery spectrum are consistently stressing the importance of reducing this stigma to provide hope and to create pathways to recovery. So we're joined here by Dr. Mark Weiner, Dr. Sheba Sethi, who will probably hop on momentarily, Dr. Brendan Sullivan, and Tim Shrukath. So would you guys like to introduce yourselves in that order? Just tell a little bit about who you are.
All right, I'm Dr. Mark Weiner. I'm the director or medical director of substance use disorders at St. Joseph Mercy Hospital, Ann Arbor, and the medical director of IHA Recovery Medicine. We provide care to people with addiction who are coming into the hospital for other reasons. And we also treat people in the outpatient setting for ongoing continuity of care. It's a pleasure to be here.
I'm Brendan Sullivan. I am in the current addiction medicine fellow at St. Joe's Mercy in Ann Arbor. Currently at this time, the only addiction medicine fellowship in the state of Michigan, and one in about 70 programs in the country. I did my residency at Henry Ford Hospital in Detroit, and just had a really interest in continuing to learn more about the disease of addiction, and look forward to spending some time with you here today.
Thank you, Brendan. Tim, do you want to go next?
Yes, I'm Tim Shrukath. I'm a peer recovery coach with Home and New Vision, and my current position is currently located in Packard Health. I'm typically out of the Ypsilanti office. And I don't think Dr. Sethi is going to be able to join us for this afternoon. She wasn't able to get her schedule blocked out at Packard.
Okay, that's fine. Thank you so much, Tim. So I want to kick us off with a question. What are the biggest barriers that a person's internalized stigma creates when they're seeking help and support?
This question sounds so familiar. I feel like we addressed it earlier. But I can start us off, we can hear other, because there's a lot of different sides to this, but I think that the internalized stigma, which is manifest mostly by the patient feeling different from everyone else, less than everyone else, and unable to, in this particular context, unable to believe that they can lead a path to recovery, that they're going to be trapped in their addiction forever. And there's a number of things that create that, and probably dismantling those things would be the greatest way to prevent it. But one, it comes from, witnessing in their own life times when they really tried to change their behavior and seemed unable to do that. And therefore they came to the conclusion, the false conclusion, that they're broken and they never can be better. And so the things that are going to reverse that would be things that turn it upside down. We talked this morning about the importance of improving people's social interaction, because people are usually very, very alone when they reach us in the depths of their addiction. That can be very effective and a very powerful thing. If patients are willing to entertain mutual self-help groups or 12-step recovery or group therapy, they can, make contacts with people who are just like them. So that would kind of dispel that they're different. And most importantly, connect with people who have been like they are and got better. And it gives them that thing that they're missing, that which is hope. And so anything that I think that can create hope that people can individually get better it's gonna help with that internalized stigma that they're eternally broken. And I'll That's all I have. I'll pass on to someone else.
Hey, Dr. Weiner, I'm pretty sure you started us off this morning too. um, for the way that I see it is every internalized stigma barrier is just ginormous. They're all so significant that it is really hard to parse out which one is biggest. The notion of it being internalized is that it's believed. The person actually believes these things, that they can't get better, that they don't deserve better. And when it's believed like that, it is a part of their reality. It is their self-reality. And so the biggest barrier would be just confronting the existential crisis of taking apart my reality and rebuilding something that gives myself, attributes my self-worth, rebuilding self-respect.
Brendan, do you want to comment on that as well?
Yeah, for for me, for these patients, you know, a lot of times when we do our initial assessment, of a patient that we're just first meeting, you know, we talk a little bit about not only just the onset of their you know drug use or alcohol use. We also ask them about any you know type of you know adverse childhood events, which is I think been kind of an area of increased interest recently. And so this is just really relays just the impact of these experiences, you know, in early childhood that go on to affect them the rest, you know, the rest of their life. And so, as I think as a professional in dealing with this, it can be a little daunting to try to, you know, as Tim mentioned, you know, this is their reality, and trying to break it down and trying to adjust it. You know, if this has been their reality for you know nearly their you know entire existence, and that's a pretty significant barrier. And I think there's that also is reflected on if they've tried to undergo recovery, you know, you know, in the past, if they've had attempts where it's you know been unsuccessful, or you know they don't, I guess, you know, appreciate that as physicians we see relapse as part of the disease you know process, and we actually I think you know anticipate and expect relapse. That we don't necessarily see that as a failure. We just you know see that as just another opportunity to pursue recovery. So especially you know just all these events are just compounded upon you know years before we even you know our first interaction with the patient.
Just a comment, reading the question again, you know, the biggest barrier of the internalized stigma is that they don't even try to get help. Is we never meet them because they're so sure that they, like Tim pointed out, their reality is such that they can't get well. Why take the time to, you know, talk to an addiction expert or someone who's in recovery to help them get better? I think Dr. Sullivan and I have a really interesting opportunity is that when patients are in the hospital and they put in a consult for us, we just walk in the room, you know, so they don't have virtually much of a choice whether they're going to meet us or not. They do have a choice of whether they want to talk to us. I mean, it does happen fairly infrequently that patients will just kind of kick us out. Mostly, most of the time, they're actually looking forward to talking about how to get better from their addiction. Sometimes they have no idea what we have to offer. And occasionally we'll get kicked out the first time we walk in, which makes the second time we walk in really important. So, but yeah, preventing care, not getting care is probably the biggest problem.
I think something really important to point out, based off of what you just said, Dr. Weiner, is that internalized stigma has very little to do with them wanting help. They do want to get out of the addiction. It's that feeling of they can't or they don't deserve it. And so in that instance, in that situation at the hospital that you guys have, it is a very different dynamic where you walk in and present it to them. The real struggle with the internalized stigma is in all the situations where it would require them to come in. And that makes it a lot harder, like you said, that the initial engagement doesn't occur. They just simply don't ask because they've internalized it.
Tim, can you talk about the process a little bit at Packard? So we've heard a little bit about the process at St. Joe's. What's the process like at Packard, and you as a peer support specialist, how do you play a role?
My role at Packard is kind of two-part. Just it being a primary clinic, any of the providers can ask me to come in and talk with a patient they have that has endorsed substance use or is in a contemplative or even pre-contemplative state where even if it is simply a harm reduction or that experimentation of just like, well, let's try to reduce it. Let's try some differences and see if it makes a difference in your life. And then as far as the medicated assisted treatment goes, it typically begins with them coming in to see one of our clinicians, or I guess by now at this point, telehealth or by phone or video, for an assessment. So that would be like one of our social workers or I guess one of our social workers. And then they have an initial appointment with one of the providers. I think now we have 5 that provide Suboxone care and XR Vivitrol. And a big boundary that we have is time there. And that's something that really I'm at a loss as to how, with the current system that we have for care, how we would get around that. I mean, it's a brief window where they're willing to ask, where they're confident enough to ask, where they have that feeling of they can and they want and they deserve. The want sticks around, but the willingness, it doesn't. And so it will often have people, come for the assessment, but not for the provider. Or with telehealth, it actually has shown drastic improvement there because it removes so many boundaries. There's a lot more reasons why I can't get to an office than why I can't pick up a phone. But it is something that is definitely time sensitive. There's been a lot of coordination with, I know St. Joe's emergency department has made a lot of progress on providing Suboxone care to patients and getting them set up with follow-up appointments, but it's still, there's a lot of issue with time that comes up.
I love that you're talking about this narrow window, and I thought I saw Dr. Weiner and Dr. Sullivan nodding their heads about the narrow window. I'd like to hear everybody talk a little bit about that, and also to sort of work it into how we address internalized stigma. So you know that you have this narrow window of time when they're willing and ready to engage. How do you get in there quickly and help them recognize that stigma is a challenge and work through it? What do you advise for them?
Well, it is a challenge because, as Tim pointed out so well, the internalized stigma, the beliefs are very rigid, and it takes usually some event, crisis, or psychic change to get someone ready to make a change in behavior. Like we have an advantage again in the hospital. If something bad has happened, something out of the ordinary has happened because they're in the hospital, so we can kind of focus on that. But what we try to do is during that period where they are at that point of desperation where they're willing to make a change, to provide something there. They're ready to reach out for something at that moment. And so sometimes you have to be creative. You know, in the hospital, we want to create, or even in the clinic setting, you want to create something that connects you to the next thing that they have to do. So whether it's like, I'm going to see you in 2 days, and here's some things, easy things to do. Well, we don't say easy because they don't think they're easy, but I want you to journal this. I want you to go to a meeting. I want you to talk to your primary care doctor about so-and-so and follow up and see where they go in that period of time, but do it immediately. Don't follow up a month from now, and don't. What I've instilled on the Dr. Sullivan, I hope, is that even though someone flatly refuses help, they told some doctor they wanted help, they tell you they don't want help, it doesn't mean that tomorrow won't be the golden moment to connect with them. And I think it for people who work in the field, especially physicians, it's very different than most other specialties of medicine, where patients are kind of looking forward to meeting you all the time to get to the next way of getting better in their life. It's very different in addiction medicine. You run into people's moods change, their desires to change from day to day, and you always have to be persistent and positive, and creating some connection to the next event could create that change.
Yeah, I mean, we kind of harp on this interaction in the hospital, because I think it is a unique situation, in terms of someone sick enough, that they're going through, withdrawal, where they're in the hospital. We can see him. Let's take alcohol, for example, day one, day two, they're just going through, just severe withdrawal. And a lot of times I'd come back to them the next day and say, hey, do you remember that conversation we had? And they're like, no. So they're just not in at least a physical, state. But something drove them to go to the emergency room to seek help. Even, either I can't do this anymore. I get this a lot that says, I'm sick and tired of being sick and tired. And so we can intersect that time frame where there's that physical withdrawal standpoint that they just physically feel terrible and know that this is not something that they can realistically continue. And I think when we get involved, we oftentimes say, look, do you have a primary care doctor? And they're like, well, yes or no. Well, do you have a lung condition? Do you have a lung doctor? And so, well, you have an addiction, we're your specialists for that. And so I think being able to reach out and connect with them 2 days, 4 days after discharge and say, let's see how you're doing, because addiction is a chronic disease. It can't be, we know realistically we can't, establish recovery in one hospital episodes, but we at least provide them that you have, a place to follow up, within the healthcare community. And I think that a lot of times in a lot of places that, that I've seen, that doesn't exist.
Tim, do you want to weigh in on that?
Yeah, I mean, something we've seen at Packard plenty of times is that that window doesn't actually open until they're there with the provider, and they actually get that feeling of help is here, that the care is being provided. Part of the internalized stigma that comes up is, we hear quite often patients not wanting to openly discuss their needs because they don't want to be viewed as a drug seeker. And that's because they, frankly, have drugs sought in the past. And they've internalized that that's what they will appear, even though they're simply discussing their medication. It takes a lot to differentiate that. But I mean, the brief window opens and closes. Like I think it was Dr. Weiner said, day to day, it can be different. So it is very important early on to have the consistent follow-up. That's something that we've benefited a lot from having a peer, where I don't have to have the rigid schedule that the providers do. It doesn't, I'm not loaded patient to patient all day. And I can just kind of check up in a more formal basis, or more casual basis, I mean. Because it will be, they'll show up for their first appointment, but not their second, because they haven't found a piece of stability yet, and they've re-internalized all the stigma, or they, had a lapse in that first week, and so they think that all is lost. But like Dr. Sullivan said earlier, it's we can't expect that perfect change, and it's really communicating that each time the window gets bigger, each time it stays open longer. And that right there is evidence that the internalized stigma is at least starting to go away. That openness, that willingness, that honesty, all those things start to increase. And that's when you can really start to see the change.
Sometimes I think just the communication to the patient that, listen, no matter what mood you're in today, what willingness you're in today, we're here for you no matter what. Here's our card. You can call anytime, whether you relapsed or not. And I've had patients have really strong reaction to that, because their prior experience with the healthcare profession is the real perception that the doctor wanted them anywhere but in front of them, out the door, out of the hospital. And we talked about that in the morning. It's because the, addiction is not taught in medical school, and where once you understand something as a physician, it's easier to have some compassion because you understand it. Without any understanding, it's harder to be compassionate. And I see doctors struggling with that. So sometimes just the patient knowing that somebody who wants to help them will be there for them, begins to break down the internalized stigma and open the window that Tim was talking about. They see more opportunities to get help after that.
So you said something about understanding, helping to overcome mistrust, maybe. Do you talk to patients about internalized stigma and what it does, what you've noticed as a provider that it does to derail a course toward recovery? Like, how do you communicate that with patients?
I don't think you've used the word internalized stigma to a patient during a visit, but we talk about ways that, where I'll tell patients that, listen, the only thing that's going to get you well is you, and the only thing that's going to stand in your way is you. And it depends on which one of you want to develop, and so I will talk to patients when they've had slip-ups or problems or just having struggles, about the reality that they've created, and try right there to take it apart. Because if they feel that they can't get better, or they're always less than, or they've had these feelings their life where they don't fit in, we'll start talking about ways where that's really not true. Because no statement is all, it can be interpreted the same way all the time, 100% of the time. People who say they don't fit in, well, there are times that they have felt like they fit in. There are things that they have fit in with. There are things that we can outline. It's what's their ideal? Where do they want to go? Talk about what their vision is for a better life and how to get there. And those things, I think, directly confront the internalized negative reality of the internalized stigma, so that patients can get out of that place.
Yeah, I've had certainly a few patients who, after a relapse or after a slip up, even like apologize to me. And I think that just shows like the amount of shame that I think that they just carry with them. that's the last thing I want, really them to feel is, I think, medicine, we're not here to be paternalistic. We're not here to direct and tell you what to do. I think Dr. Weiner's mentioned kind of to me in the past that we're your medical consultant. We're not your lawyer. We're not your priest. We're not your your policeman. We're just we're your consultant for your medical care. And this is medically what I think you should do in the future. But when I get patients apologizing to me, it just, I think, really speaks to the amount of shame and like what Dr. Wander said, I don't use the word internalized stigma kind of directly, but indirectly, I just try to break down some of that shame and just let them know that it's a part of the disease process. We expect and we anticipate relapses or slip-ups.
Tim, this morning you talked a little bit about the importance of community in helping to overcome internalized stigma. Can you reiterate that for this group?
I think that it's twofold at least, probably more, but to me, recovery is primarily for myself, and something that I've witnessed and experienced with other people is about being able to have real healthy connections with other people, and not superficial or codependent, but just genuine, intimate connections where there's trust. That can come within and outside of the recovery community. There's no part of internalized stigma is the consistent notion that there has to be a meeting per day. I think that I've never been told that for any other medical condition I've had. My mental health, my physical health, nothing. Substance use is the only thing that I've been told I need a meeting per day, I need sober supports, I need a sponsor. While those things are all super beneficial, that it enforces to me that it's different. While I would never encourage anyone to not go to a meeting, not get sober supports, not have a sponsor, to have the agency removed to do these things, and to be told I have to do that it perpetuates that internalized stigma. But I think I'm a little off topic there. And the community is hugely important because stigma, the way I understand it is it can't be internalized unless it's received externally. If it is, it's not internalized stigma, it's negative self-talk, it's negative self-image, but the stigma component is that it's cast upon us. And so in the recovery community for medication-assisted treatment, there's a stigma there as well. And that makes it harder to engage in these programs. And so to think that this is something that I have to do, but I can't talk about my problems in this community. I can't talk about my recovery openly and honestly because I will be stigmatized. I've heard it referred to as drug replacement therapy. And that's stigmatizing the medical care that they're receiving. And I've witnessed multiple people carrying that shame with them, and they begin buprenorphine maintenance and are all too eager to get off of it immediately, as soon as possible. But that's not necessarily, that's not the point of it. And the internalized stigma that can be removed by the community is the community at large, outside the recovery community, it seems that if we just treat people with substance use as people, with basic human dignity. It's something that Dr. Weiner had mentioned kind of earlier with people that aren't familiar with it. There is a sort of anxiety with encountering it, because we all have an image of substance use in our minds. We've all had it for a long time. Through popular culture, through the media, through all of these things, we have an image of it. And if it's from TV, movies, whatever, it's typically a scary image. But they are, people with substance use disorder are just individuals who are suffering. And if the community could begin to see it that way, then the internalized stigma would change so much, because they would not be treated as degenerates. People with substance use disorder would be seen as suffering people, as opposed to, just another junkie, which I hate that word, but it really conveys the power of the stigma.
I think that's a real important point, and that stigma, definitely the source of stigma is from outside of the person experiencing it, which is exactly where the healing has to come from, and yeah, you can heal internally probably on your own. It's possible, but sure helps if you have a community of people who have healed in the same way and accept you for who you are, and provide encouragement and hope. This missing piece, hope that you, like many people say who are early in recovery, I don't think I can have fun again or go to a concert again or do all these different things, because I won't have drugs anymore, so nothing's going to be fun, or I won't have alcohol anymore, so it won't be fun. To be around a community that supports that, the opposite of that belief, that, yeah, you can be part of, you can be welcomed, you can be happy, and you could have recovery at the same time. I think that the recovery community is so important, and I do not think that we would have as much people recovered from addiction if it wasn't for the recovering community. That said, the stigma within the recovering community around medication-assisted treatment is harmful. I mean, it's harmful. I mean, just to say it, it's harmful to people who need it, and there are people who do. Just like I talked about it this morning, everyone's care has to be individualized, and sometimes care to addiction needs medication, sometimes it doesn't. I think the goal for a lot of people, is to get abstinence completely, and sometimes medication is part of that pathway. The recovering community itself has traditions regarding, or at least one particular tradition regarding, issues that are outside of recovery, which is they don't have an opinion on outside issues, and therefore probably shouldn't have an opinion on the medical treatment of particular patients. And that does create a lot of difficulty. However, I will say that in the Ann Arbor community, more and more patients who are on medication-assisted therapy have been welcomed over the last few years than it was, say, 5 years ago. But there's still a long way to go, and there's a lot of negativity in certain groups or meetings that the reaction of the patient is exactly what Tim said. A patient comes back and says, I need to get off this right away. And they're going to, and not take into account that they've had multiple life-threatening relapses where they've ended up on a respirator and nearly died several times this year, and they want to stop suddenly. And but we can take those situations and usually point people in the right direction. But it does create a huge challenge, even within the recovery community, that some of the stigma exists regarding some of the treatments we know are very effective for certain people and life-saving. So it's a challenge that we run into frequently.
And there,
So medication-assisted treatment is a form of harm reduction. Can you talk a little bit about other forms of harm reduction and whether or not you think that those strategies could help overcome stigma?
well, if I may, really quickly, I want to comment on two things Dr. Weiner just said. Especially, first, the significance of the recovery community. There is quite possibly the most powerful experience I've ever experienced is walking into a recovery meeting and feeling normal. Being in a room of people that understand, that truly get it, they've shared the pain, and I can speak about it freely and not feel like I'm making someone awkward, like I'm making somebody uncomfortable. They've been there, they know. And the other big thing that I can't remember exactly what he said, Dr. Weiner, but it really sparked a long, it was maybe the internalized stigma can be repaired by the self, maybe, but just from my personal experience, the past few days, I've had such significant anxiety about this because of my internalized stigma. I'm 4 years sober, and I still have this affecting my life significantly. And I don't know that the way things currently stand, that will necessarily go away, because there is still stigma. But it is something that is pervasive, and it is something that is long lasting. And a lot of, when he said that, it made me realize a lot of this conversation has been, and I agree that the immediate effect is hugely impactful, and actually engaging in treatment, but there also needs to be long-term look at it. That it down the road, however long, it can still be something that hinders engagement and further care that's needed. If you could please ask your question again. I got a little distracted, sorry.
Well, the question was just about whether or not harm reduction could help mitigate the effects of stigma, internalized stigma. And I think you spoke to it a little bit there, for sure.
Yeah, I think we also talked this morning, about a couple examples of, harm reduction, and I think more so in the field of substance use disorders compared to other diseases, diabetes, high blood pressure, that these concepts of harm reduction just generate a lot of just emotion, especially when you have the discussion of, say, naloxone, Narcan. There's some debate on on terms of that. Some people feel like you're encouraging the use of drugs, knowing that there's like a life-saving medication, and then you have a completely opposite perspective that every patient who has a substance use disorder should receive the medication. And so I think that's something that even within like our community, the medical community, that I think that's something that we continue to struggle with, in terms of, you have a lot of physicians who are not in the field of addiction medicine, that if you ask them, because there's a lot of patients that are taken care of by non addiction medicine physicians, would you consider referring this patient to a needle exchange program? Would you consider a Narcan prescription on discharge? And I think a lot of physicians would say no. And so I think it's a big. I think there's a lot of room to improve regarding harm reduction. I do think that by having those conversations does, I guess, reduce the internalized stigma. Is because if you talk about harm reduction, you're normalizing the addiction as a disease, and you do treat it appropriately when compared to other diseases.
I mean, as we talked about in the morning, my thought is harm reduction is just under the umbrella of taking care of a patient and improving their quality of life. And you address the harms and how to reduce them in any way you can, whether it's through referral to different resources, whether it's prescribing of medication, whether it's simply coming up a plan that is right for as far as the patient's view of their quality of life, even though it does not necessarily meet the goal, like a gold standard of complete abstinence, and to be okay as their provider with where they are at that time. But part of what our care should be for everyone, and no matter what their condition is to point out where they could be harmed or killed as a result of their behavior, and to find ways to mitigate that. And those are huge successes, I think. Eliminating the chance that your patient's gonna die is huge in any specialty. But like some patients who may come to me after a horrible relapse and they say they're beyond help, and I think my comeback is that no, you're still breathing, which means you can be helped. There's still help for you. And I think, but at any point, reducing the chances they're going to be harmed is just part of a treatment plan. We can call it harm reduction. It's got a special name in addiction treatment, but it really is just about saving a particular patient any way you can.
Yeah, to speak to the emotional aspect of the conversation, Dr. Stolzen, when you mentioned that perspective of not prescribing Narcan, I felt myself get a little bit fired up. Like we wouldn't deny somebody an EpiPen because it might encourage them to eat shellfish. And that's just, yeah, I got fired up. But Dr. Weiner made a good point there. Harm reduction isn't simply about reducing the harm. It's about shining a light on the harm. It is a two-pronged approach of giving them a way to reduce that harm, but also to make them aware of the harmful actions of addiction and the things that are causing so many life-threatening problems. Yeah, I think that was an excellent point.
As a community, we've been doing a lot of anti-stigma campaigns over the last, I'd say, year or so here. Most of them are focused on external stigma, so the way people view people with substance use disorders. Are there any approaches that would focus on changing people's perceptions of themselves that you've heard of in the broader community?
That silence is unfortunate. But unfortunately, it isn't something that's easily approached. It is part of the individualized aspect of addiction treatment, that each person's internalized stigma is different. Each person has different experiences and identifies with different there's such a variety of ways that stigma exists and is presented and inflicted upon people with substance use that everyone internalizes it a little bit differently. So there's no one size fits all approach. I mean, the best place to begin is the community's, the public's perception of substance use disorder and just the day-to-day treatment of somebody with recovery or in recovery or with substance use disorder, like being able to find employment, background checks, various things like that can, I mean, discrimination in that respect exists, and it's incredibly hard to prove. Discrimination in general in a lot of ways, but it's something that affects every facet of a person's life from the point they get into recovery on. I mean, federal student loans can't be obtained if you have a drug conviction. So I can't go to school and better myself. I can't advance my life. Well, it's because, you know, I'm an off person. Those sorts of things that reinforce sometimes years down the line. Those negative self-thoughts, the internalized stigma. So, I mean, really, it's the best place to start is just that local community, and just the day-to-day treatment of individuals with the basic human dignity that we all deserve.
I was thinking I had the pleasure of sitting in on one of the Sure Moms programs this year, and just learning about the curriculum and what they do. I'm not sure if you've heard of that. It's for originally for mothers of justice-involved youth, but their approach is that, you know, that all of these mothers face trauma of their own, and that they can't just support their youth without supporting themselves. And so they actually have sort of this evidence-based curriculum that focuses on the impact of trauma and also self-care. Are there similarities within your community?
Well, I can talk about our patient care regarding that, what you talked about, we just mentioned. First, I wasn't silent before because I didn't have anything to say. I just was being polite for someone else to start, because I always got things to say. You know, I talking about how to eliminate stigma is exactly what Tim said. In what I've shared before, we have to teach society, you know, that for addiction, it's, you know, it's a disease. It's not a moral failing. It's not a lack of will. Although the morals and the will are manipulated by the addictive process, it's not the problem. The problem is there's an addictive issue going on. It's a chronic brain illness. When more people understand that, the stigma should begin to lessen. But how do you take care of someone who already has it, and what techniques do we use? Generally, you know, it's interesting. You can call it, how do you get rid of stigma? And I think, well, how do we get rid of stigma? Oh, it's what I do every day when I'm taking care of patients. I just don't call it that. It's connecting with successes they've had, using motivational interviewing to reframe some of their experiences and looking at what they have done and focus or show a light of where they have actually empowered themselves to do something, and saying, you've done this before when X, Y, or Z happened. You can do this again. And here's a way you can do this to help yourself get out of the trap you are in with addiction. So there are ways to do it. They're ongoing. It's an ongoing process with individuals, and it will be an ongoing process and a lifelong. I don't think my career is, you can run out of things to do, because there's just so much that needs to be done to educate the healthcare profession and the community at large regarding that. Trauma, though, you mentioned trauma, and I'll tell you that is, I also take care of patients with chronic pain. I take care of patients with addiction, and I take care of patients with chronic pain and addiction. And one thing I've taught Dr. Sullivan, I hope it was probably new information, is that we start off just about every interview with every patient with, you know, at any point in your life, do you feel that you are a victim of trauma or abuse? And the percentage of people who report some sort of trauma, it's above 80% in my experience. You know, I have a selection bias. I see people who are really, really sick in the hospital, and people who have sought help, and maybe it's different if you look at the whole population, I don't know, but it's extremely high. And the same is true for people with chronic pain. And with chronic pain and addiction both, it's probably even a little bit higher. So we usually incorporate identification that there is an unresolved trauma, grief, or loss as early as we can, and incorporate some sort of referral to therapy to get that treated. There are some excellent therapists in the community here in the Ann Arbor, Ypsilanti area who focus primarily on trauma and addiction, trauma and pain. However, most of our patients do not have the right insurance to access it. So there is still a huge gap in managing that. And the untreated, unresolved trauma, grief, and loss that could be treated through appropriate therapy is a huge gap, and probably underlies most of our failures in managing patients individually. Some of that can be addressed through group therapy, mutual self-help, but often directed individual therapy is needed for a lot of that, is what I've experienced with my patients.
Yeah, I mean, in terms of, I think the one of the other challenges in kind of, I guess, breaking down the internalized stigma is we do, I think, even when we use the term like, people with substance use disorders, I think a lot of times the perception is that they're focused on people who are actively using, who are not in sustained recovery, whereas, we can also look at a patient with a substance use disorder who that's in remission. And that's a spectrum of, that it's a spectrum of the disease process. And I don't think we get enough of, people who are in sustained recovery, advocating, and, I don't think we give them enough of a voice to really help break down that internalized stigma. So I think it is good to have like these sessions like today, where you do bring it to the forefront, and I appreciate Tim, being as part of this panel, and having a peer recovery coach, and having that, ability for people who are in sustained recovery to share their story, not just in the context of a recovery meeting, but in the context of outside that setting.
Tim, there's a question for you here. Have you seen it in the chat? Could you talk a little bit more about how you overcame your anxiety about today's session and the steps you take internally when faced with uncertainty or doubt? Are there steps you walk yourself through? Maybe lessons you can share with others?
Overcoming my recent anxiety, something to what Dr. Weiner had just mentioned, with individualized therapy being very important, is CBT techniques. Consistently reality checking myself, that I do have important things to say. My voice does matter. Just challenging my negative self-talk in an objective way. Because the statement of I'm worthless is, or I'm not good enough, or any of those things, like when you really look at it, it is just, it is a ridiculous statement. Everyone has value. If nothing else, I can donate an organ. There is intrinsic value there. And so to really just consistently reality check myself. I also have some very good supports in my life. Speak to community again. People that I could really talk it through with, and Um, I mean, it's something that, for me, a big part of my recovery, recovery Dharma is a mutual support group that is Buddhist based, and sitting with the feeling. It's very uncomfortable to do, but my experience has been that the reason that negative emotions are so persistent, or the emotions I deem negative are so persistent, is because I try so hard to not feel them. And the emotions that I deem positive are so elusive because I try so hard to feel them. And that right there is addiction in a nutshell, of trying to avoid the bad and trying to hold on to the good. And to just kind of sit with the anxiety and just let it be, and just be okay with the fact that I'm anxious. Everyone gets anxious. It's not me. It's not a problem with me. It's not that I'm broken. It's not that all of these internalized stigma statements of I am the problem. It's a natural experience. This is the first time I've ever done a panel like this. Of course I'm anxious. I mean, and to consistently reality check myself and to just let myself be anxious and to be compassionate with myself about it, goes a long way to a big part with stigma is to normalize it. I have to normalize it with myself. I have to remind myself that I feel these things for a reason, and reason is because I'm human. That's as simple as I can state it. I feel like there's a second part to that question.
So the steps that you walk yourself through.
I feel like I kind of in there. I mean, there's not really any step-by-step process. It's a lot of it is just when I catch it. It's something that can really run rampant without me even being aware. And as soon as I become mindful of it, is just to really pause and to really experience it for what it is. And that's the only way that it's going to pass, for me at least. That's been my experience, is to just recognize that it's there and be okay with it. It's way easier said than done, trust me.
Final thoughts from our panelists?
I feel stigmatized. You didn't ask about my anxiety. I mean, come on, we're people too.
I'm sorry.
It's not you, Tariska. But anyway, you know, everybody feels anxiety. And I think that, you know, we run into some, yeah, Tim, you're doing great, by the way, if this is your first panel. I think all of us are afraid to speak publicly, and all of us are afraid of a lot of different things, and it causes this feeling of anxiety. I do have some experiences though with patients who have the same sort of thing, whether they're in addiction or not, but they don't want to do something. They're afraid of something that makes perfect sense for them to do and something they should not be afraid of. For people in addiction, it's often like going to their first 12-step recovery meeting. I hear many stories where people like, well, they got the appointment, they put the appointment in their calendar. That's as far as they got, or they got to the drive, you know, the parking lot, but then they turned away. And I think it's what Tim was talking about, and what I try to do with patients who are in that situation, and myself, if I'm in a situation where I'm anxious, is try to either put into words, what am I afraid of? What am I really afraid of right now? And try to identify how much of that is real and how much of it is just made up, because that's what we do. I mean, as human beings, we're actually, fear is a real important feeling. It keeps us out of danger. You know, we kept this feeling for a reason. Those people who weren't afraid to, you know, stand at the edge of the cliff or at the bottom of the valley, you know, the ones who are afraid are still alive. So it's an important thing to pay attention to, but it can at times be out of proportion to reality. oftentimes talking with a patient and I'm talking with them, they can verbalize it. Verbalizing it makes a big difference. Patients talking to their supports and sponsors about their fears seem to make most of the fears just magically disappear. And that's just the way, as Tim pointed out, human beings work.
Brendan, final thoughts?
Not much more than what's been said across, not the one, but two sessions. So, no, I just, I think it's, for me, I do enjoy, kind of working in this field. I mean, it can be frustrating, but it's very, very rewarding, as well. And so I'm also, just pleased and excited to see that, events like this, are happening, are out in the forefront and are available for not just the medical, community, but for, the general public. So, yeah, I just said, thanks for having me as part of this panel, and, and I'm just encouraged by the work that is continued to be done.
Well, I'll finish with a little anecdote that one of my colleagues, old colleagues, used to say with patients, is anxiety is, the evolution of anxiety is why we're at the top of the food chain. Like Dr. Weiner was saying, we can plan for danger. And back when we were, evolving it, like hunter-gatherers or cave people, you take two of them, two hunters, they're getting ready to go, and one of them says to the other, like, oh, my significant other and I got into a really big fight last night, and I'm really anxious about how we're going to resolve it. And the other hunter looks and says, I want to eat tonight. Why are you worried about that? Like, we got to deal with getting dinner. We have to deal with feeding ourselves. And when that became a part of the human condition, we had so much more to legitimately life or death worries. Social evolution is way outpaced that, and we still have all of that within us. We just don't have the same sort of constant life or death. If I get a splinter, I don't have to worry about getting sepsis and dying. And something that really helps me with my anxiety is to place it in that tangible perspective of that it's supposed to be there. It is something that, because I don't have all of those life or death worries constantly, my mind runs rampant on me, and it creates the monster behind the door when it's actually just my little kitty. But yeah, that anecdote crossed my mind when Dr. Sullivan, I don't remember exactly what she said, but something small triggered it, so I wanted to throw that in.
Thank you for sharing that. And thank you for being here and for all that you do. And I think if anyone has any questions, you're welcome to email us at the Opioid Project, and we will put you in touch with our panelists to get answers. So again, thanks so much for taking the time today, and blessings to you all.
Thanks for having us.
All right.
Thank you.
Thank you.
Bye.